This is EHJ Today at the annual scientific sessions of the American Heart Association in Chicago 2014. And I'm talking to two distinguished clinical researchers, particularly in the field of post-MI, remodeling and heart failure, to Mark Pfeffer. He's now professor of medicine at Harvard Medical School and Brigham and Women's Hospital, and to Bertram Pitt, who is professor of medicine at the Medical University in Ann Arbor. Welcome, gentlemen. So, Mark, tell me a bit, why is HFpEF important, and why do we have to do trials in heart failure with preserved ejection fraction?
Well, it's actually a relatively new diagnosis. I would say 1980s. Some smart people in the nuclear medicine lab kept saying, who are all these people that are coming to me with a diagnosis of heart failure that have an ejection fraction of 60%? And then that concept, diastolic heart failure, emerged. And the more it's studied epidemiologically, it's for real. There are 40–50% of people being admitted for heart failure that when the measurement is made, the ejection fraction is greater than 40%. What do you do with these people?
Exactly.
So, you know, at first, what's happened is operationally they're different because the medications that were used, the neurohormonal antagonists, haven't been shown to be helpful. So then we have this quagmire. They have signs and symptoms, they are suffering, and we don't have a proven therapy. So here we are, 2014, we still don't have a proven therapy.
Yes, that's a bit depressing. So what do we do about it? So you started a trial to...
Well, then I turned to Bert.
Okay.
So let me just say the diagnosis is a little difficult because it's a normal ejection fraction and you have symptoms, but those symptoms can be vague, and you can have shortness of breath because you're obese or lung disease. So you need some other criteria. You need some structural abnormalities or some biomarkers, but that's been the problem with all the trials. They've had a heterogeneous population, including TOPCAT. So TOPCAT was a trial sponsored by the National Heart, Lung, and Blood Institute, where we randomized 3,345 patients who had, we called HFpEF, on top of whatever they were on. Blood pressure was well controlled, and the intervention was spironolactone at a new dosing strategy. We had pills made up of 15, 30, and 45. The usual pills at 25, 50. The reason we did that is because these were elderly people. We wanted to be cautious how we up-titrated, but nevertheless, we were able to achieve good doses, and we randomized these patients, followed them for approximately 3 years, and at the end of the day, there was a trend toward a reduction in our primary endpoint, which was cardiovascular death, resuscitated cardiac arrest, and hospitalization for heart failure, but that was not significant. Exactly, yeah. We did, however, note one component was significant, that was heart failure hospitalizations, as well as total hospitalizations, and we were disappointed with this result. But then we noted something, that about half of our patients came from Russia and the Republic of Georgia, half came from the Americas, Canada, US, Argentina, and Brazil. And when we looked at the placebo event rate from Russia and the Republic of Georgia, it was 1/4 of that in the Americas, and it was at a level that was not compatible with anything we've seen in epidemiological studies or in previous randomized studies of heart failure. In fact, if you look at it, it's just about the age mortality rate you would expect from a normal person in Russia and Georgia. So that led us to more closely investigate these differences, and Mark has just analyzed that, and he will tell you about some of the differences we found.
Mark, yeah, that's interesting.
We've all done trials. They're all multinational, and the more countries you have, the more variability you have. But we're not talking about the effect of therapy. We're talking about the placebo group. And that made us really look under every rock. So then if you do that, you find that they're distinctly different populations. So under the same umbrella of the term heart failure with preserved ejection fraction, as we're going to present here, two distinct populations, 38 baseline characteristics, 34 different. So it's, they were just different patients. the prognosis was totally different too. So that made us do this post hoc analysis. What was the effect of spironolactone in the Americas and in Russia and Georgia?
What was the event rate roughly in the two?
Well, if you annualize per year, 2% something in Russia and Georgia, and about 12%, so 4 to 5-fold different on the primary event rate. And that was for the primary, and if you did mortality, which I like to look at any clinical trial, show me the mortality of the placebo group, and what Bert just said is just distinctly true, that it's what you'd expect from life table in Russia and Georgia, whereas in the Americas, it was multifold more, consistent with having heart failure.
Right.
So that led us to then say, well, let's look at what spironolactone did, not just for the outcomes, but on things we expect. So if you look at potassium change, there's a 3-fold higher incidence in having a potassium of 5.5 or greater in the Americas, not seen in Russia and Georgia. If you ask about hypo, 50% less hypo, 3.5 or less in the Americas, not seen in Russia and Georgia. Creatinine, a 60% increase in the incidence of having a doubling of creatinine out of the normal limits in the Americas, not seen in Russia and Georgia. I have one more, which is systolic blood pressure. The change over the first year, not significant in Russia and Georgia. The change in the Americas, 4 millimeters of mercury, statistically significant. So with that, that led some of us, and not all of us, to say, look, this post hoc analysis is important for doctors to take notice of.
Sure.
Now let's look at the events. Bert said the primary was not so in the overall population. So in this post hoc analysis, we had a significant reduction. We had a
In the one group.
primary in the Americas, and then if we look at the components, without using a p-value, I'll use the 95% confidence interval. The 95% confidence interval for cardiovascular mortality and hospitalization for heart failure, each independently excluded one. So we think this is
striking reduction in cardiovascular mortality, about
20-something% reduction in cardiovascular death. So we think this is something physicians should know about because there is nothing else. And I tell Bert, as I look over my shoulder, there isn't another big study coming up. Right. And these patients are there every day. It's a big percentage of heart failure. And so if we have a tool, a generic drug that could help them, with the caveat that there's a safety issue. Yeah. You can't just write a prescription and walk away. Right. If you do that, please don't do this. But if you monitor carefully and down titrate and follow somebody's potassium creatinine, you have the opportunity to reduce, I believe, to reduce their cardiovascular morbidity.
And it was really very safe. We saw hyperkalemia, but there was no deaths related to it. In fact, in the Americas, deaths reduced. We saw some increase in creatinine, but the people going to dialysis were even less on spironolactone than, at least numerically less, than placebo. So it was really very safe, and we have a clue that in the Americas and the right people, it's really working.
But what was the renal function to start with?
Yeah, we had more people with a EGFR less than 60 in the Americas, and considerably more, 40% versus 20%. That
there was a limit of
yes,
GFR?
oh yes.
What was the limit?
30 is...
Yeah, that's important for...
It's contraindicated.
Yeah.
It's contraindicated below a GFR of 30.
I think that's a very important take-home message. Huh? So you first have to look at the patient, your GFR,
and
your
measure potassium.
And
potassium should be below 5,
yeah.
and the GFR should be over 30.
And then you can start with a low dose, and then you may up-titrate and check...
check after every dose titration, yes. Check after starting, yes.
Right. So I think that's a very important message. Where can we read about this?
This is coming out in circulation, e-published at the same time as the presentation here. And I think people should look at all these because we are giving post-hoc analyses. And I think if you look at the data plus the supplemental tables, it's all there.
Good. So what is the future of HFpEF? Just to finish with a last comment, is there anything at the horizon that
There are many new studies ongoing. There are studies with LCZ 696,
Yes.
the ivatabrine, many antifibrotic drugs. So because of the fact we've not had anything that's been overwhelmingly positive, there are a number of, I think, very promising things being looked at. But until we have that data, it seems to me if I had a patient with HFpEF, spironolactone would be what I would use.
Well, that's very interesting and important for our listeners and viewers. Thank you very much, gentlemen, for sharing this with us.